Good afternoon, everybody. Respected Chairman sir, Chairperson sir. Actually, it is very difficult to talk about this difficult and boring chapter of limb reconstruction in the post-lunch session. If anybody feels sleepy, please tell me and I will stop my lecture. I have lot of experience with Dr. Patro to arrange conference like this in Howrah Orthopedic Hospital. So I feel very proud to come here in his invitation to give this lecture. So what is limb reconstruction? Human locomotor system maintains laws of physics. So if there is any problem in this system like deformity, length discrepancy, or in between the system, if there is any problem, there is altered biomechanics, and this leads to various symptoms. So aim of limb reconstruction is restoration of altered biomechanics by deformity correction, correction of limb length discrepancy, and restoration and repair of damaged bone, and finally to save a limb. The principles of lengthening is first to do osteotomy in the bone, then gradually distract the segment. The in-between portion consolidates by itself. We have to keep the periosteum intact as far as possible. So different types of hardwares are available to do these things. One is Ilizarov fixator, rail fixator system, hex support system, or we can hybridize between the two systems according to the need. Now the procedures is shortened long bone is fixed with fixator maintaining the anatomical axis. Then multiple drill holes are made at the proposed osteotomy site and low velocity osteotomy is done, keeping the periosteum intact as far as possible. Now osteotomy is kept undisturbed for 1 week for organization of hematoma, then gradual distraction at the rate of 0.5 mm to 1 mm a day. Whenever the desired length is achieved, the fixator is kept in situ till consolidation of bone. The patient is allowed to full weight bearing, walking with support, physiotherapy for mobilization of the joints, and fixator is removed after consolidation complete. Now this is an example of female patient 19 years old with 5 cm shortening of right lower limb. We did a femoral lengthening, the length equalized. This is the range of movement of the patient. Now this is another patient of 24 years old male with 4 cm shortening. We do the same procedure and the length equalized. But how much a single bone can be lengthened? The answer is maximum 5 to 6 cm without damaging nerves and vessels. So what to do if the discrepancy is more than 6 cm? Let's have an example. This is 11 years old female with 13 cm discrepancy. Left is shorter than right. Now the problem is her right lower limb is growing normally. So our prediction is there will be 16 cm discrepancy at the age of 16 years when she will get the maturity. So the plan is to do a multiple lengthening. This is the pre-operative gait of the patient. Now we did a femoral lengthening and gained 6 cm, and in the second stage we did a tibial lengthening and get a 5 cm. So when these two procedures are completed, there is 2 cm discrepancy left. We remove the fixator, patient allowed to grow and further consolidation of the bone. When the patient returned at the age of 16, the discrepancy came 4 cm. So we did a third lengthening at the 17 years of age, and you can now compare the length of her 2 lower limbs with the post-op pre-op pictures. This is the range of movement of the patient. Now this is another case with 22 cm shortening of left lower limb. This is a congenital femoral deficiency, and you can see the shape of the femur. Now she had an associated hip deformity. So if we do a lengthening in this type of hip, the coxa vara hip, this will obviously dislocate. So first stage is to correct the hip deformity by doing a corrective osteotomy. Our aim is to prevent dislocation on subsequent lengthening. So in the second stage, we did a femoral lengthening. And in the third stage, we did a tibial lengthening. So we gained 6 centimeter femoral length, 5 centimeter tibial length. She has residual of 10 centimeter. Patient can walk straight with raised shoe. Our next plan is to do another lengthening after 2 years. So the same principle can be used for restoration of damaged or diseased bone. Suppose this is a long bone and this portion of the bone has been damaged. So we can remove that bone, do a osteotomy there, and then suppose this is the damaged bone, we remove that portion, do a osteotomy there, then gradually transport the segment and the in-between segment consolidates. And then to supplement the docking site with bone graft. So this is an example of fracture both bone leg treated by plating, and there is post-operative infection, exposed metal, sequestrated bone and soft tissue damage and loss of skin. So we resect the infected bone, fixator is applied, flap coverage was done, and distal osteotomy. You can see there is 6 centimeter bone gap. Now we transported the segment upwards, and the 6 centimeter gap has been completely overcome. So there is consolidation of both transportation and there is union in the second healing of the wound, and after that we expose the docking site and bone grafting was done. Fixator is kept till final consolidation of both osteotomy and the docking site. This is the final result of the patient, and this is 1 year follow-up of the patient. This is another case of fracture shaft femur treated with plating, post-operative infection, discharging sinus, loosening of implants and associated deformity of the foot. We remove all the infected bone, fixator applied, and did a proximal osteotomy. In this case, we transported the segment downward. Here is the osteotomy and the gap. We transported the segment, and 7 centimeter gap has been filled up, and there is regeneration of osteotomy. Both union and docking sites are consolidated. Now, not only linear direction, bone segments can be translated to any direction. So for this, we require a special type of fixator which is known as hexapod. Hexa means 6, pod means limb. Actually, the concept came from robotics, where desired movement is done by 6 sets of motorized limbs. These fixators also have 6 adjustable limbs, so that this fixator is adjustable in all planes. These distractors are numbered from D1 to D6. Now let's see how this system works. This is an ankle deformity. He has a biplanar deformity both in AP plane and lateral plane. So we fixed up with hexapod fixator. This is a post-op X-ray, and this fixator comes with a computer software. This software can simulate the exact nature of deformity. This is the deformity in AP plane, and this is the computer simulation of the deformity. The same thing in lateral X-ray, computer simulated the deformity. From that simulation, computer calculates how much the plane to be adjusted to make the axis straight. And from that, we get a calculation that how much the distractors 1 to distractors 6 to be adjusted. We give this program to the patient, and you can see after application of this program, the deformity has been completely corrected. The axis becomes straight, and this is the pictures after removal of fixators. This is another case of genu varum, varus deformity of the knee. We fixed with this type of fixator, computer simulation of the deformity and how much it will be corrected. This is immediate post-op, and you can see the displacement of the bone and axis has been completely corrected after the procedure is over. This is the picture after removal of the fixator. So limb reconstruction does not complete without the discussion with the